All right, thank you today. Thanks for joining us today. I wanted to first introduce myself. I'm Jeff Weiscarver, president of DDME, and the purpose of today's presentation is to introduce you to the GEMPro product and provide some information on why you would need it and how to use it. So with that being said, I'm going to go ahead and get started. I did want to point out before I start the presentation, there are 3 handouts on the control panel. So if you're attending live and you have you look at the handout section, you'll see that there's some handouts there that we made available for you. Okay, so let's get started. The unmet clinical need in dentistry, the way we see it, is the OSA in America is on the rise, and it's primarily due to obesity. There's some other reasons, but for the most part, we're getting bigger, and bigger people have worse airways. If we agree that airway abnormal parafunction and OSA are linked, then we can also agree that parafunction is on the rise. There's a linearity between obesity, OSA, and parafunction. So as a result, today's dentists just can't afford to ignore this. I mean, obviously they may choose not to treat sleep apnea, but in the course of doing dentistry, we need to at least be aware of the impact that these these links have on our day-to-day dentistry, and then develop a strategy to manage them better. And so the image that you're looking at there, it says parafunction in 4 minutes. On that image, those orange boxes are apneas. There's some blue lines there. Those are hypopneas. Those are types of airway issues. And then just above it is the surface EMG. And you can see after almost every single one of those apneas or hypopneas, there's a parafunction or a clench. And so the temporal association leads credence to the relatively new accepted that parafunction and airway are related. So this is evidence of it now. So the idea that we should not be taking this into account is getting antiquated. We really do need to have a plan for these patients. I wanted to talk about idiopathic bruxism, and by that what I mean specifically is parafunction or a clench or a grind that has no obvious trigger. So it's a disorder in of itself compared to parafunction secondary to an airway issue. So if you look at these 2 images, look at the red box, and just prior to that giant clench you see, they're totally normal breathing. It's absolutely normal, and then the patient just has an enormous clench. And then there's this is what I would call idiopathic bruxism. This is, I think, what most people think of when we talk about bruxism and tooth wear. However, what we've experienced is what's going on the right. I believe this is more significant than the image on the left in the number of people that suffer from it. So if you look on the right, again, there's those blue boxes, and you can see how linked they are to the clenches and grinds. I mean, it's one for one. It's exactly, you can see each one of those boxes has a bunch of parafunction associated with it. The tooth wear that's going on the right happens as well as tooth wear on the left. But as a dentist, how do you know what you're dealing with? So again, this is the idea, is if we can manage triggers, then we can manage this parafunction. Okay. The other thing I like to add, just real quick, is let's treat, in cases like on the right, we can treat the cause, not just the symptom, and that's so important. Okay, so let's talk about the GEMPro. So the GEMPro is designed to be able to manage this, the determination is what your patient has. So if they have tooth wear, and you want to determine if the tooth wear is from kind of true idiopathic bruxism or if it's parafunction secondary to OSA. Okay, so with the GEMPro, this is what you can expect. Improved restoration outcomes involving implants, crowns, and bridges. Okay, why would that be? That is because if we can eliminate the triggers, the parafunction can be greatly reduced or go away. Occlusal overloading is a primary cause of biomechanical implant failures. Okay, so that's something that we just need to deal with, and we can. In certain circumstances, we can greatly reduce the risk of this happening, and so we can, if your occlusal, if your overloading is, if you reduce the risk of that, then by all means, how do we do that? Because the implant failure is, we all know what grief that causes. Number 3, the single arch splints are associated with increased airway complications. Okay, so we need to know that if you don't know why your patient has tooth wear, and it happens to be that they have airway problems and parafunction, and you put a single arch guard in, those have been shown, statistically speaking, to compromise the airway further. So you're protecting the enamel at what cost? Okay, so if somebody has an AHI of 15 and you put a guard in them and now they have an AHI of 25, okay, you've protected the enamel, but consider what's going on with the patient. That's just not, that's an avoidable outcome is the way I'll put it. Number 4 is associated with that, reduce the risk of occlusal guard causing inappropriate outcomes. Okay, we can protect the teeth, but let's make sure we don't cause a worse side effect. Number 5, this is a great thing that the GEMPro does. You can titrate your oral appliance from the patient's house. So we have the technology, and I'll talk about that in a second. But at the end of the day, if you could titrate, keeping the patient from having to go back and forth to your office, 6-8 times, so wouldn't that be a good thing to be able to do? Number 6, a lot of people are skeptical of this, but I don't see why you would be. If somebody has parafunction and they haven't damaged their teeth yet, and you could detect the parafunction and do something, then tooth wear is preventable. From ever. I mean, if you got a 22-year-old kid in there and he's clenching and grinding, got a little bit of snoring, and you learn about it, he hasn't done any tooth wear yet, yeah, you could save that guy all that grief. And number 7, if you want to treat snoring, treat snoring. If you don't want to treat sleep apnea, then refer those patients out. The key on number 7 is, you have to have the wisdom to know the difference between snoring and OSA. And the GEMPro provides that for you. Okay? Okay, practices, let's dig in a little bit on restorations just for a moment. Determining the underlying, why are we doing restoration work? Okay, if we could eliminate or greatly reduce that reason, wouldn't it stand to reason that we would want to do that and then do the restoration or implant? Think about it. If we stabilize the oral cavity and then do a restoration or an implant, that implant has a much better chance of being successful. Reduce parafunction by using the appropriate treatment appliance and protocols. So if your protocol is, well, I just put a guard in everybody, and it works every time, well, yeah, it protects the enamel every time. And that's what guards are designed to do. I'm not, negating the benefit of the guard, but what if we could protect the enamel and reduce or eliminate the risk to the airway? That's what I'm getting at. Number 3, reduce parafunction leads to less warranty work. Duh. I mean, at the end of the day, wouldn't it make sense to stabilize that oral cavity and then end up, improving the outcome of your restoration? If a person has moderate to severe bruxism and an airway issue, and we don't know that, and we're going to do some implants, that implant has a higher risk of failure. If we determine that the airway is triggering parafunction and we have a treatment plan accordingly, then we reduce the pair function and improve the restoration outcome and reduce the risk of a failure. I don't mean to be flip about that. It's a great opportunity to improve the outcome of implants. Improper tooth strategies can lead to increased OSA. We've talked about that. And incorrect protective appliances can increase the parafunctional activity. So even though you might have something protecting the teeth, we might be chewing on that more because we're causing more airway triggers, and as a result, more parafunction. Okay, so we're making some bold statements here. So I wanted to back it up with a little bit of research that we've done. So like the first one, temporal association between sleep apnea, hypopnea, and sleep bruxism. Okay, so there's a lot of I wouldn't say controversy, but in some groups there's reluctance to say this causes that. So when we talk about temporal association, we're just describing, okay, an airway event happens, and then right after that there's a parafunction. In my mind, this is an easy in some patients. It's easy to tell. If they go on their side, the parafunction goes away. We have positional bruxism. Okay, that sounds almost silly, but to me, if you've observed positional bruxism, the airway is causing the clenching. Risk factors in the general population. This is a good study because it was done by very famous pulmonologists. Christian Guilleminault invented some of these airway issues that we talk about. Airway protection, the missing link between bruxism and sleep apnea. I know Gerald Simmons very well. I trained under him for a couple of years. Sleep bruxism related to obstructive sleep apnea. Okay, how is it that CPAP can make parafunction go away? Yeah, that's why I included that, because that paper studied that. So on these research articles, there's guards in the airway. There's not a lot of research on that. Okay, so I have two references here. There's a literature review, the second one that does a fairly good job, and then the first one there is a pilot study. And the pilot study was done with known apneics, and they put a single arch guard in known apneics, and about half those patients got significantly worse as far as how we measure sleep apnea. All right, implant overloading, that has been studied quite a bit. And so there's really no doubt that if you're clenching and grinding and the bone's trying to fuse with the metal and there's pressure, especially with these one-day implants, the fusion is at risk. The bone metal fusion is at risk just due to pressures, and that makes a certain amount of sense. DDME, we did our own research in this, and it was an informal, I would call it a pilot study. It was done similar to the Gagnon study I just mentioned, except for one important difference. The Gagnon study studied 10 known apneics. We did 14 patients that were treated for tooth wear and were provided guards or occlusal splints. Okay, so what we did is we did 2 nights, one wearing their guard and one without, so that there was a baseline and then one with their splint. And we found that 10 of the 14, the AHI, this measure, apnea-hypopnea index, how we assess the severity of apnea, the AHI on these 14 patients went up. Some of them not so much, and some of them dramatically. I would say, 10 of the 14 went up. 8 of the 14 went up dramatically. So I would say that, but 4 got better, and sometimes significantly better. So the idea here, I think the takeaway here is that we should know what's going to happen to the airway when you do a guard. And if a person, if you do a study and there's oxygen desats, you have to be skeptical of what the guard's going to do for you, the overall benefit. You have to compare protecting the enamel or for whatever reason you're putting a guard in, you have to weigh that against what the impact is that your guard's going to have on the patient's airway, and we should know what the impact is, and we can find that out with the GEMPro. Okay, incorporating testing into your practice. So if you're a practice, so I divided practices into two categories: treating OSA and not treating OSA, because I fully recognize treating sleep apnea is not for everyone. In fact, it's not for most, to be honest. And so should you just, not even consider this, anything that I'm talking about, or should you do at least some monitoring and then refer out those patients who you learn have an airway issue or need to be treated for OSA? I think it's great when we refer out. It's good for the patient. If the patient gets the help they need, why not? Okay. So on these two categories, if you're treating OSA, screen your patients. Start them on an easy to test. If the first thing you say is, "Oh, I'm sending you to a sleep lab to be diagnosed with sleep apnea," that's a tough entry point. If you say, "Listen, I'm going to send you home with a couple sensors, just clip them. One's a watch and the other one's a little clip. Wear it, and then we'll see what we're dealing with, and then we'll take the next step." The second thing that the OSA practice, the practice treating patients with OSA, sleep apnea that is, you can titrate the appliance. So for those of you that may not know, when you're treating sleep apnea, obviously we're going to move the mandible forward over time with the idea that we're going to open up the airway and make the airway patent so the patient can sleep soundly. And it's done over time because we're applying considerable pressure to the system. So you can do that from the patient's house because the GEMPro actually transmits the report from the patient's house, so they don't have to go back and forth all the time. Okay, so that's the two upsides for the practices treating sleep apnea patients. Again, the GEMPro does not diagnose sleep apnea. It just gives you an assessment of the risk that the patient would have, okay, of having sleep apnea. Okay, so the second category, practices not treating OSA. Prevent excessive tooth wear. Okay, so what do we mean by that? If, find out why, tooth wear. If you learn that tooth wear is secondary to airway, you can decide what you're going to do with your airway-related patient. Refer them out. Get them to a sleep lab. Send them to a dentist that does treat OSA. And then we have a product that kind of buys you some time there, and I'll talk about that in a second. Improve restoration outcomes. I talked about that. Add snore treatment to your practice. So the tricky part with treating snoring is distinguishing the apneic from the snore. And the GEMPro does that. And know when to refer to your physician. So historically, you would maybe do a questionnaire, or maybe if you're tired and your spouse says you snore, then you say, "Oh, listen, you need a sleep study." Most people kind of know that already. If you do a test and you show them a graph, that's probably a little bit more powerful referral, because if if somebody fills out a questionnaire and they're tired, like I said, and maybe they're kind of predisposed to apnea, most people kind of know in the back of their mind. They say, "Yeah, I'm 25 pounds overweight, I'm 50, I'm tired in the afternoons." They know that. But okay, so if you've done a test and you show them there's some oxygen desaturations, now they're confronted with some physical evidence, and they might be more inclined to accept the referral. Okay, so let's talk about how this works in the context of your practice and what DDME offers. Okay, so what we offer is the GEMPro. It's a quick and easy test that every dentist, well, I'm selling it, but I think it's a great test. It's easy data to get. It is inexpensive. Once you own the unit, your first 50 tests there is no cost except for whatever time you want to put to a couple of minutes. And then after your 51st patient, the little EMG foam pads are 80 cents. So it's 80 cents a test. and to be able to distinguish all the things that I've talked about. To me, that's 80 cents well spent. Number two, customer support and services. We know that to sell a thing is the easy part. To be able to use the thing effectively and help your practice, that's the hard part. So we offer service over time. And so, you know, our relationship starts when you buy a system. It's not over, okay? So we do have customer service agreements or contracts that have all kinds of benefits. One of the nice benefits about the dental screener agreement is that if you do want to diagnose a patient, maybe you want to start dabbling in treating patients that have been diagnosed with sleep apnea using an appliance, give us a call and we'll send out one of our diagnostic instruments to your patient, and then we'll give that data that you've ordered to our group of physicians, and then they'll look at the data, diagnose your patient, and then make some treatment recommendations. You know, we do that for a small fee, and try it. You know, you don't have to buy the unit. It's basically you're renting it for a day, and if you find that this is something that you do want to get into, you've kind of got into it in a smart fashion. So often what happens in dentistry is somebody like me will sell you a really nice instrument, and then it doesn't get incorporated into your practice. So then, you know, there was an investment, and then it didn't yield some of the benefits that it potentially could have. To avoid that outcome, just sign up for an agreement, and then you have access to the instrument. And then if you're ordering these tests and you're paying these rental fees, just buy yourself one. You know, and then now you kind of have a practice already in the works. And then, you know, we do use a very, very nice full diagnostic instrument. It's in my opinion the best in the market. Okay. All right. So now I'm going to do is spend a couple minutes on training you on how the GEMPro works. Okay. There's 5 channels that we record: oxygen, heart rate, bruxism, snoring, and all those by body position. Okay. So there's 2 sensors that collect those 5 channels. The 2 sensors are on the left. One is an oxygen oximeter, a wrist oximeter. And then the second is the little clip. I showed a picture of it earlier that goes kind of on your collar. And then you see the surface EMG pad goes on the masseter. Okay. There's a tablet that receives the Bluetooth transmitted data from those 2 sensors, and it can sit under the bed or on a nightstand or a dresser somewhere in the bedroom. It doesn't have to be next to the patient. You know, all 3 items come in a kit. The sensors are rechargeable, so if you're going to do multiple nights, just plug them in. They use pretty standard USB chargers. You can see the chargers in the case. And then there's the card there that gives instructions. All this, the point of all this is to get that report, the report that you see there on the right. Okay. It's kind of a close-up of the kit. You can see the oximeter plugs in. So how that works is you unplug the finger probe and you plug in the USB cable. For our amplifier, you use the plug that you use for the tablet. So when you're charging during the day, you're not going to need the tablet charger, so just use that to charge up your amp. And then at night when you're doing a study, use that same cable on your tablet. The tablet needs to be plugged in when you do a test. The tablet only has 4 to 5 hours of battery life, so it has to be plugged in. The 2 sensors obviously have 8 to 10 hours of life on them. Okay? So make sure the devices are always charged up. Just plug them in the morning. And by the time you're ready to do the test, it takes about an hour for them to get charged up. Okay, so let's talk about the tablet. Okay, you don't see the tablet on this image, but this is what the screen of the tablet looks like when you log in as a prescriber. So the tablets have 2 modes. One mode is the prescriber or the dentist mode, and the other mode is what the patient sees. We're going to talk about what the dentist or prescriber sees. So this is what the steps you take when you're going to send this unit in preparation of sending the device home for a patient to do a test. So this is a not unusual screen. There is a demographics section. So there's a unique patient ID, and that's a, you basically decide what that's going to be for you. I think most people are using their medical record number, but you could do anything you want on there. Patient name, that's easy. Email, date of birth, height and weight. We'll calculate the BMI. If you prefer metric, you just click where it says imperial, and it switches that to metric. Now the PIN. There's 2 PIN boxes there. One of them is really not active yet. So where it says report and save data PIN, ignore that for now. We're developing a product that we're going to come out shortly, and it'll be for that product. So you only ever worry about report only PIN, the one on the left. It'll always start with an R for report. So your 4-digit PIN is what the PIN is assigned to your patient. So you've typed in Johnny Jones, Johnny's email, and all his height and his weight, and then you're going to give him an appointment card or a little post-it or something that has RAHR on it. Obviously it won't have that code, but when you do your tablet, it'll generate a code automatically, and you give that code to your patient. And then you should take a note of it too, because if the patient loses that little piece of paper, they're not going to be able to do the test. Okay? You click register. Oh, I forgot to mention, you can also assess the type of tooth wear. We're doing some research at a couple universities, and they asked for this. And here's the 4 types of tooth wear, and then how many teeth are affected. This slide here is just kind of reiterating what I said earlier, that we're using the report only PIN and not the report and save data PIN, okay? So when you click next, what we're going to do at this point is we're going to turn on the amplifier and the oximeter. So I remember on the screen I told you to click next. Another screen is going to show up, but before you get too much farther, we got to turn the amp on and turn the oximeter on. The oximeter has a little blue button on it, and there's a little black tiny switch on the amplifier. And when you click next, this is the screen that you come up to. What the primary, this screen does two things for us. It does the kind of gives us some test information. How many nights do you think? By default, it goes to 3, and the minimum number of hours should be 5. I mean, it's not required, but it's a good number. If you want to make it 6 to try to get your patients to sleep longer, that's not a bad idea. And then there's a drop-down list of reasons why you're doing the test. The other thing that this screen does is it pairs the Bluetooth sensors to the tablet. So all you have to do is, like on the previous screen, you turn the 2 oximeter and the amp on, and then you click scan. And the tablet will look in the environment for whatever sensors it can see, and you'll see numbers pop in to the EMG and the SpO2. Okay, and then we're done. So then you just click done. It'll say the tablet's ready. Okay, and again, you're going to be getting ready to give this to a patient, so make sure you have that 4-digit PIN ready to go. All right. So now we've exited out of prescriber mode, and now we're going to sit down with our patient, and we're going to explain to our patient how they're going to do the test when they get home. Okay. So again, here's the kit. Explain to them this is the kit. They're responsible to keep it in good order, take care of it, bring it back in this condition that they got it. There is the laminated card. Personally, what I like to use is demo mode. So the tablet has, you know how I told you about the 4-digit PIN that starts with an R? If you're in the tablet and you're getting ready to go into patient mode, you can actually type in DEMO in capital letters, and it will let you kind of show the patient on the tablet what they're going to see when they get home. That card, that laminated card, that's handy. That's nice to have, but I find that if they are actually doing what they're going to be doing on the tablet, that's a little bit more effective training tool. So I would encourage you to use demo mode. So type in demo, say while you're typing in demo, say when you get home, you're going to be typing in these 4 letters, and you give them that appointment card or post-it that has those 4 letters on it. Okay, so then it's going to let them in. And then at this point, they need to turn on the amplifier and the oximeter, and they need to plug in the tablet. and they don't really have to do anything except what I just said. Plug the tablet in, you'll get a green check where it says tablet plugged into power. When you turn on the oximeter and turn on the EMG device, it will automatically detect them, and then you'll get a green check, and then you start swiping. So you swipe from right to left. The first time you swipe, it might be a little tricky, but after you do it once, it's easy. It's one of those kind of things. Okay, so now we're on screen 2, and you'll notice there's a bunch of little dots up here. We're on screen 2, all right? Applying therapy, any type of mouth guard, and then you swipe. And on this screen, it's telling you how to apply the amplifier to your collar, and then put the surface EMG pad on your masseter. Say locate masseter by clenching your teeth and feeling for your, there's a typo there, I should say cheek muscle to bulge, not check. Okay, so I'll fix that. And on this screen here, this is where they would apply the amplifier and the surface EMG pad. And then on the surface EMG pad, there's a thin plastic sheath that covers the adhesive surface. Just peel that off, and when you find your cheek muscle, then you put it on a vertical orientation on the masseter. Okay, so it's important that it be vertical, so the two snap-ons are in a vertical orientation. The confirmed body position. So when you clip the body position or the amplifier to your pajamas or shirt, just make sure there's a big black arrow kind of pointing up. That the amp needs to be in the up orientation in order for the body positions to be accurate. Okay. Oximetry gets worn like a watch. So the body of the oximeter goes on your wrist on the non-dominant hand. And then the finger probe, just pick a finger. The index finger is the most popular. But I also mentioned to people, if the finger probe is uncomfortable, you can switch fingers. There's no harm in that. And because sometimes, if you wear the probe and it's pressing in one spot for like 4 hours, you could wake up and it might be a little uncomfortable. So I just tell people, if you experience that, just move it to the next finger. And then it's much more comfortable. Okay. All right. So I'm going to spend a second talking about clench. We do a calibration on measuring how strong a person can clench when they're awake. So you hit the play button on this, and then there's kind of an animation. The guy's forehead there will tell you what to do. So it'll say clench for 3 seconds and relax for 7 seconds, I think it is. And then that bar will go up and down based on if you're following the instructions. So it's kind of a feedback. So we get 4 strong clenches from you. And then we kind of remember that for later. So just know that we now have a thing called a BioCal value. Okay. So once we have the BioCal value, then we listen to the room noise. And we use kind of a noise canceling feature, so we subtract the room noise from the snore signal, and then we just are left with the snore. What we're finding about our snore, it is really, really sensitive, and we can we're actually going to have to make it less sensitive because I think in some people it's misinterpreting loud breathing as snoring. So, the thing that's nice about the way we do things is these updates are really easy to do. And we just send you an email and say, go to Play Store, go to DDME Bruxism, and click the update button, and then you have your update. So, but yeah, I mean, our snoring is fascinating what we're learning. So once we're done with the audio calibration, then you're ready to start the test. And by default, the timer is set to 10 minutes. You can start the test immediately if you like, or you can set it to 30 minutes. If you're a person that takes a long time to fall asleep, then you might want to do that. From this screen, this is the data acquisition screen, and the green line around the circle, that is actually orange until you hit the blue hash mark, and then it turns green, meaning you achieved the length of time goal. In this case, if you remember, it was 5 hours. At any point in time, if you want to turn off the blinking LED light, you can just click that LED button and on the tablet, and it turns off the blinking green light on the amp. Okay. When you click End Test, what happens in the morning is the tablet goes through a gyration, makes a calculation, and it sends the PDF report to the dentist, and then presents the data, some graphs on the tablet. So you can go through and look at all the different channels, and then you click Finish. So after the PDF report study is sent via email to you, you get this little screen that says, okay, you finished, click OK, and the patient's done. And they just they pack everything up, or they wait for the next day. Okay, so let's talk about the report. A couple of things about the report: the graphs, the SaO2 graphs. These are what we would call candlestick graphs. So each one of those lines represents some amount of time, seconds, and then we see the range of the SaO2 in that amount of time. So rather than do all this averaging that a lot of oximeter companies do, we actually report the full range, and we do much less averaging than the other, our competitors do on this particular channel. The heart rate, you see it there, is pretty handy, especially in the more mild cases, because sometimes you'll see, very few DSATs, but a lot of heart rate variability. Bruxism analysis. So again, what we do here is the taller the spike, the stronger the clench. So, and then because it's body position related, if you see a big spike right at a position change, you just know that that patient's kind of moving positions. If you see spikes within the color realm, then we know that those are genuine clenches or grinds. Okay. And on the cal voltage, you can see we have the BioCal max force. That's from the calibration that we did before the test, where we had you bite down 4 times. And there's the value. And then while this patient was sleeping, their max value was actually higher. It's 273 than their waking maximum force. So that's not that unusual, though. And then underneath, we've been the clenches and grinds and bursts by how strong they are. So the first 2 boxes are basically bursts. They're weak clenches, or you could call them a weak clench, or in the literature they're referred to as bursts. The 50% or the middle one where it says 13 and then 1 and 1, those are clenches or grinds, and those are categorized based on their strength. And then the last channel there, or last graph rather, or second to the last graph is the snore. And the taller the graphs, the louder the snoring. Okay. And then finally, there's the calibration that I was telling you about. Okay. All right. So that's that. I'm going to go through some case studies, and then we're coming up on the end. So with the case studies, the first case study that we have is a 66-year-old male who's had a couple of heart attacks, was prescribed CPAP, and almost immediately became non-compliant. And he's got some tooth wear and has a guard that he doesn't wear either. So what we decided to do is do 3 nights with this patient, a baseline, and then a night with him wearing his APAP or CPAP machine. APAP is, just so you guys know, most CPAPs that are prescribed now kind of automatically sense the pressure that you need, so they kind of call them autopaps or APAP. So we did a test with that, and then we did a test with his guard. So this is night 1. His low SaO2 was 80, which is pretty low, and he has 68% below 92. That tells me he's got a low baseline, and we know that about him, so we confirmed what we knew. 17% below 89. Okay, that's significant. And 2% below 85. That's, in my mind, if you have any time in that middle box, he has 17%. That's highly a high risk of having sleep apnea, very high risk. Okay. Heart rate analysis, that's pretty straightforward here. You can see he has some amount of bruxism. He really does, he clenches, his biocal was 134 and his night force was 124. But he has a fair amount. If you look at the spikes there, especially on his back, you look, when he's on his left side, there's not much the first couple hours. And then he moved to his back, and there's quite a bit of bruxism there. So, that's another case. And then on the snoring, you can see that the snoring is also positional in the last graph. Okay. All right, so that's his baseline. Next was his auto titrating unit, and you can see he did a lot better. His low was 84, which is still fairly low, but I think that's an artifact, because you can see right here. So it looks like his low is actually probably around 90. So yeah, when you see a kind of a spike out of the ordinary like you see right here on this one, so that 84, yeah, again, I'd say his low is probably 88. One of those sets there. Okay, you can see his percent time, 66 and 13 improved. He had no time below 85. That's good. His heart rate improved somewhat. His clenching and grinding went away. So CPAP resolved his bruxism. We see that a lot, and it's. I think the more we think about this stuff, the more hope there is on bruxism, because there are things we can do about it, and there are things that we can prevent, and so on and so forth. He did snore a little bit on his back on CPAP, but not much. All right, so what happened when he wore his night guard? So this is the third night with him with his night guard, and total relapse. In fact, his SCO2 got slightly worse than his baseline. His heart rate was essentially unchanged. Now the guard did a great job of reducing the bruxism. So, but look what it did to the airway. What cost was this protection? And then the snoring was better. I guess there's a little bit of vertical dimension improvement there. That might explain why his snoring's a little better. Okay, so I'm going to do one more case study here, and this is a true bruxer. And when I use the term true bruxer, I mean it's a person that we don't know what the trigger is, or there is no trigger, and it's just the patient that bruxism is its own disorder. So this is a 56-year-old female who has had 12 restorations, reconstructions, what have you. Knows there's no question what the problem is. So we did 2 nights on her. The goal was the dentist. The complaint was she wasn't compliant because she's sick of purchasing new guards every 3 to 6 months. Apparently she has such a bad problem that nothing lasts more than 6 months, and so she's going in there a couple, 2, 3, 4 times a year and spending a couple $100s on these guards, and she's just sick of it. So we did a baseline, and then he made her a guard that has some wire mesh on the posterior part, and we're going to see what happens. So on her baseline, on the left, her SCO2 wanders around, but there's not a lot of DSATs. So this tells me that she's moving around a lot. She's not sleeping well. She's probably awake and asleep a lot. And her heart rate reflects that. So I'm pretty sure that's what's going on here with her SCO2. Her bruxism is a catastrophe. So her biocal max force is 113, and then when she sleeps, it's 400. So that's pretty bad. And you can see by the binge data at the bottom, she had, let's see this, so that's 40, she had 79 clenches or grinds. So that's a lot. I mean, so on the right side is her wearing this new guard. Now I want to point out, look how much better her SAO2 looks And look how few body position changes she had. So she sleeps much better. And she's sleeping almost entirely on her back. All right. Look at her heart rate. You know, this downward arc is what we expect to see when people sleep normally. And look at her bruxism. You know, 95 was her waking, and then 51 was her max compared to 397. And look at her bin data. She only had 2 clenches or grinds. That's it. That's amazing. So we confronted her with the data, said, listen, we have something that works. It's a durable appliance, and have at it. Be compliant with this, and you can see how well it works. It even helps her sleep better. Okay, this slide here I like to put in because it just shows how what positional bruxism looks like. So the guy sleeps on his back, is in red. He's got all kinds of DSATs and all kinds of heart problems. And then on his left side, everything goes away. So this is just a case of, this kind of proves our point that in so many cases, bruxism can be managed and eliminated. All right, let's talk about diagnosing patients. So when we're diagnosing patients, we have a device. If you get a GEMPro and you decide that's the route you want to go, and you have a service contract on the GEMPro, you have access to this piece of equipment. Okay, so for a fee, we're going to send it out to your patient. We're going to pay the physician out of the fee, and we're going to use our equipment, and we'll diagnose your patient for you. Okay, and it's a way you can put your toe in the water without buying a $5,000 or $6,000 instrument. If you are using this a lot and you're paying a lot of these rental fees, then maybe at that point in time, then you make the investment because it's working. It's a working model for you. Okay. The hookup for this is listed here. It's a more complex instrument than the GEMPro. It collects enough data to diagnose your patients, and I think it's a great instrument, and it does collect surface EMG. Okay. All right, here's what now the model for the medical diagnostic instrument, it records the data on a drive that's built in, and then you take the device back to your office, and then there's a download. So you plug in a USB cable and it downloads this data, and at some point in time, if you want to get into treating patients with diagnosed sleep apnea, we'll train you on how to read these screens, but for now you really won't need to know much about that unless you want to. Here's a report. We talked about the AHI a little earlier, the ODI, the oxygen desaturations. There's a count of clenches and grinds per hour and snore index. Here is actually a report from a physician. And the physician will provide 2 things, a diagnosis and a code. And then the second requirement for an interpretation is treatment recommendations listed in the order which they're recommended. Okay, so there's always going to be like an A, B, and C. So A is the first thing that you'll recommend. And this thing, the patient may benefit from the use of nocturnal mandibular repositioning appliance. Okay, final topic. The BRX Pro. The BRX Pro is a dual arch occlusal guard, and it's a transitional unit, meaning it's not a long-term solution. So just a real quick story. When I was running, the sleep labs earlier in my career, it was always kind of unfortunate that we would diagnose a patient, and then there would be weeks, if not months, before their insurance authorization came in for CPAP. And in that amount of time, the patient talked themselves out of the need for CPAP. So we'd call them up and say, oh, insurance gave us authorization. Oh, I'm fine. I don't want to pay my deductible on that anyway. I can't afford it, and I'm feeling better. We would get that all the time. So the idea here with the BRX Pro is it's immediate. So, when you suspect your patient needs something, keep them engaged. And if you end up, for example, referring them out to a sleep lab, say wear this until you get on your CPAP. Or if we're going to diagnose your patient and then get them into a long-term sleep apnea appliance, say wear this, and then when your long-term appliance is ready, we'll trade. So that's the idea, is to keep the patient engaged in the process, because the same thing happens here. If you take an impression, send it out to your lab, your dental lab. It comes back, if you're lucky, in 2 weeks, maybe 4 weeks. If the patient's not that enthusiastic, when you call them and say, oh, why don't you come on in, we got your appliance, they'll say, oh, you know what, I can't afford it. Ah, darn. Or they'll say, you know, I'm feeling better. My wife says I'm not snoring now. So, you know, those are all things that happen when people have time to think about it. So again, that's the idea here. It's 2 impression trays. They're partial trays. And there's 4 positions, so we kind of hold the mandible. We're not really titrating out like a sleep appliance, because that's not what this is. But we want to prevent the mandible from going back. So we're just going to, that's why we have the 2 arches. So we want to keep the mandible in a known good position. The reason for the partial tray is we want the molars. We don't want the posterior tooth contact with anything. It's kind of the NTI concept. Okay, so if we improve the airway by giving you 4 or 5 millimeters of vertical, and we prevent the mandible from going back, and the teeth are protected, we've achieved all our goals of protecting the enamel without worsening the airway. Okay, so that's what this is. It's inexpensive. It's well under $100. Here's a published article on it. And there you go. So the rest of these slides, I think this is a good time that I say this webinar is in conjunction with Dr. Bouzis has a session coming up here in a couple of weeks, or a week, I guess, maybe a couple of weeks. And there's some different types of methods in which a practice can implement testing procedures. And, you know, this is kind of the handoff over to that session that's coming up in a couple weeks. So with that being said, I'm going to go ahead and end the recording, and thank everyone who listened for listening to the presentation. Okay, thank you.